As Fliss emphasised earlier, there has not really been much work on the implementation of outcome measures into palliative care at all. For example, what works in practice to improve care? Yes, work on what to measure. Yes, work on developing measures. Yes, published measures and psychometric study of them, but not so much on how make them work in practice, which is the implementation science behind it. I take you back to South East London for now. Marsha joined the team, as I said, very recently, and we are covering parts from South East London. We are running the OACC project with 5 inpatient hospitals, 3 community palliative care teams, and 1 inpatient hospice. Although the area is small, there is a lot of diversity in terms of our patient population. Whereas in the south live mostly middle-class, white British, elderly patients, in other areas there is a higher proportion of minority groups, for example, working class, black and ethnic minorities in much younger population. The aim of the project is to improve care for patients and families. Such as a diverse population provides us with the opportunity to reach people who are not well known to the palliative care population yet, as they belong to a hard-to-reach population, as I said, the oldest old or the black ethnic minorities and socially deprived. Where are we at the moment? It took us 6 months to get to know the teams and understand their busy working routine. As you can see, aimed for a bottom-up approach, because the tools have to work for the teams in practice and not the other way around. So we observed, we discussed, we met, we agreed, we trained and we trained again, and we start with implementation on their terms. That's very important. Looking back, it is worthwhile to spend face-to-face contact with the teams, even if it's only for 15 minutes and you travel for 2 hours. So they get to know you and feel comfortable expressing any concerns, but equally important to acknowledge their emotional impact on staff. Careful observation at the beginning about the different routines helped us to identify some of the facilitators and barriers together with the teams. If we look at Antunes et al. Paper from 2013, it is a systematic review and there were categories developed. And if you look at the facilitators, measure ask about issues that are relevant to clinical care is important. In the OACC project, the outcome measurements reflect a holistic assessment which palliative care professionals do as a core part of their routine assessment. This means that staff are able to fill in the outcomes according to the assessment they would have done. Additionally, the outcome measures could act as a prompt at the bedside to ensure holistic assessment, preferably with the patient if possible. If we look at the barriers, the example in relation to barriers in Antunes et al. Paper reflect the most common mentioned barrier in all the sites. Whilst acknowledging that it is an added task at first for the team, our role is all about to keep the staff motivated and emphasize that it will get easier as they become more familiar with the tool. Ultimately, they can prove the fantastic work they have done in improving care for patients and their families. With regards to lessons learned, Antunes et al. Found in their systematic review that training needs to be tailored to the team individual needs. This is to allow the staff to take ownership and understand the benefits of its use. And I show you now what we did by addressing the gap about educational needs. According to the WHO definition, 2012, it was valuable to discuss with the teams what they felt an impeccable assessment is. Most of the staff knew that it is a patient concern-led. It's about ongoing communication with patients and families and to assess needs of patients. But they were not aware that it implies an ongoing systematic approach using validated assessment tools. Although the term outcome measure is around for quite some time, many staff do not actually know what it means in relation to their clinical practice. All they associate it with is that it is another added task to complete. Therefore, it is important to highlight why outcome measures are beneficial in demonstrating the impact result of care provided. Having said that, although we emphasize this strongly within the teaching, you may find it interesting what the staff actually understood. For instance, some teams adapted it and were very keen to start with because they saw it as an added duty. And we all want to complete our duties well. Some teams are not clear when they will experience a benefit. At the moment, it is an added task. Some teams understood the why, and some teams feel to be in a competition and therefore want to get on with it as soon as possible. So we acknowledge their emotions, but these concerns highlight the need to tailor training to individual team requirements. In an ideal world, we would like to be in a position to feed back the data straight away in order to empower them with evidence, which is a core task of the quality improvement facilitator. However, as we only just started to support the implementation of 2 outcome measures, we are not in a position to provide instant feedback in a holistic way just yet. However, I would like to give you one practice example of an implemented outcome measurement to illustrate the individual tailored need for training. But first you may want to ask me, why teach an outcome measurement already in use? So, for instance, the phase of illness outcome measure. This is for 2 reasons only: refreshing its intended use and uniform use across sites. So on the example of phase of illness, which Fliss briefly touched on, if you go in the booklet, page 8, phase of illness definition. First you see a linear illustration. However, it turns out that it may not necessarily follow the linear process. So there's very rarely a patient comes in stable, goes into unstable phase, deteriorates and is dying, and then deceased. You may find a patient unstable, and then you may, next day, you think he's going to die in a few days now, and then he may recover a little bit, and you may expect a certain recovery phase, and then he goes back into, before he dies. So, what can the outcome measure tell us? You will soon share the same language amongst the palliative care team. For example, if you see in a multidisciplinary meeting or handover that the patient is unstable, you know immediately that you have to prioritize to see him or her as soon as possible. For instance, this phase may trigger a consultant review automatically without losing much time in the handover. If you see that the patient is deteriorating, then you may want to follow up with PRN drugs are prescribed correctly, or if she or he had physio and OT assessment done as prescribed, but sometimes during the day, so it's not urgent. In summary, teaching this outcome measure taught me that after using the same outcome measure over time, there may be a need to look at the definitions with an open mind again. So the aim of the teaching was to refresh the definitions, but also to get the teams into the swing of using the tools more than once, which makes it an outcome measure. So where to start? This leads me to the final slide, where we strongly recommend a stepwise implementation because of 2 reasons. The quality improvement facilitator can accompany the team and pick up unmet needs immediately. The team doesn't feel overwhelmed by implementing all 6 outcome measures at once. And this was a key aspect of the implementation, because first they had no time to implement all 6 outcome measures at once. But when we said, okay, let's start with the phase of illness and the AKPS, there was agreement across the sides. This supports a bottom-up approach, because the team can tell you when they are ready for the next tool to be taught and implemented. So we set them a target, said them, okay, by the end of the year, you're going to use all the outcome measurements, but you tell me when you're ready for the next one to be taught and implemented. And that works well so far. So take-home message is really the purpose of these 6 outcome measures in practice is to provide better care for patients and families. Key aspects is, and I haven't touched on that, but the executive management have to agree to implement outcome measure, which is the only top-down approach. But if that's not in place, then it doesn't work. Everything else is a bottom-up approach, so careful observation, good negotiation and communication skills from both facilitators but also the teams, Individual tailored training, very important. And OACC is addressing the implementation gap in practice and in the literature. So, thank you very much.